And what I'll do is I'll open this meeting of the Health and Wellbeing Overunion Scrutiny Committee here at the Council Chamber on Tuesday the 5th of November, 1 p.m. Item 1 is apologies for absence.
I have apologies from Georgina Hill.
Do we have any other apologies from the floor? No. Okay, Caroline Ball we've got.
I think maybe here, it's not here.
Okay. Item 2 is the minutes of the meeting of the Health and Wellbeing Overview Scrutiny Committee held on the 3rd of September 2024, as circulated, to be confirmed as a true record and signed by the Chair. Can I certify them as a true record?
Move accept, Mr. Chair.
Thank you. Okay, thank you. Item 3, disclosure of members' interest. Does anyone have an interest to declare which they haven't done previously? No, thank you. Item 4, Health and Wellbeing Board. The minutes of the Health and Wellbeing Board held on the 8th of August are attached for the scrutiny of any issues considered or agreed there. Are we happy with those? Yeah, thank you. And then I move to substantive business. First item is number 5, NHS GP access, to discuss ongoing issues and public perception of GP access both nationally and regionally. And I'm going to pass over to Councillor Patterson on this item.
Thank you very much, Chair. Good afternoon, everyone. I know how much as a nation we value our NHS, our doctors and of course nurses. However, because of my portfolio role, which is caring for adults, I wanted to bring GP appointments to scrutiny just so that we can talk about this a little bit, because we're not seeming to have autonomy in regard to different GP practices. Some of them, you know, you have an 8 o'clock remit, and if you don't get in on 8 a.m. exactly, then you maybe can't. So this was one of my reasons for bringing this today, so that we can all discuss this as a scrutiny committee. And we're very lucky to have with us Andy Stewart from Northumberland ICB and James Martin from North Tyneside and Northumberland ICB. And they're going to talk us through GP appointments and GPs in general. Thank you very much.
Thank you. So hi everyone, I'm James Martin, Strategic Head for Primary Care for North Tyneside and Northumberland, part of our ICB. So I'm just going to talk to you a bit around general practice, show you some of the data which shows kind of some of the information around what access is currently being provided in Northumberland. Talk a bit around some of the challenges that we know that there are around access to general practice and some of the things that we're doing to try and resolve those, and then we'll have a bit of time for some questions at the end. So I thought it'd be... I need to move on this one. There we go. So I thought it'd be useful to just talk a bit around what is general practice. So GP surgeries are usually small to medium-sized businesses that are contracted by us, the NHS commissioners, and they provide generalist medical help on a geographical area. So each practice is usually made up of a partnership, a GP partnership, which is a number of GPs that are collectively working together to provide that. We do have some individual GPs provide their single-handed practices, and we have some that are provided by kind of bigger organisations. So Northumbria Primary Care are an organisation that provides some of the GP practices in Northumberland. Each of those partnerships holds a contract, organisations hold a contract, and those partners are responsible for providing the services and meeting the requirements out in that contract. I think you probably all know that general practice is usually the first point of contact and by far sees the most patients across the NHS. The responsibility for commissioning those services sits formally with NHS England, but they've delegated that down to integrated care boards to provide. So there's 3 main types of GP contracts, so they're not all the same. There's a GMS contract, which is the original kind of contract that most practices hold. some personal medical service contracts which kind of provide a little bit more than a standard contract, and most new contracts are alternative provider medical services, which allows for some kind of wider provision models other than partnership. Kind of listed some of the core parts of what the GP contract includes. It's quite a high level general contract. It's not got lots and lots of details in. There are some things that are essential that practices must provide, and they must need to do that within core hours, which is 8 until 6:30 on kind of normal working days. Practices are paid in what we call a block arrangement, so they're paid not on the number of people they see or the number of appointments they do, but on the number of patients that are registered on their list. So there's a set amount that practices receive, and that's their amount kind of for the year. Obviously the list size may go up or down a little bit, but that's the kind of the amount of funding that they're working with to deliver services. So that's currently £112.50 per weighted patient. Here we go. The other thing to highlight, in 2019, there was introduction of primary care networks, which some of you may have heard of. This was additional funding into general practice to support practices to work together and come together to provide services. They're not legal organisations, they're just a collaboration of practices, and they're formed around a collaboration agreement. So we've got 6 PCNs in Northumberland, we've got kind of a north, one in the west, got some around Cramlington and Blythe, for example, and the practices in those areas have come together to look at the patients they've got and provide services. One of the big successes that they provided was COVID-19 vaccination. So a lot of that was done through hubs provided by primary care networks. So there's some practice provision and there's some wider access. So some PCNs provide enhanced access, which is appointments in the evenings and weekends, for example. So there's some patients may access their services through the practice, some may go to a hub. Okay. So just to give a bit more detail around Northumberland, so we've got 36 practices currently in Northumberland. So that's 36 contracts, but actually there's 60 sites. So there's a great number of branch sites that practices are providing, so they're providing over multiple buildings. The smallest list size we've got is 2,000 patients, which is small. The largest is 50,000, which is a huge practice size over multiple sites. The average is around 9,400. So, and that's increasing over time. So the list sizes on average are getting bigger and practices are getting bigger. We have 6 primary care networks, which I just mentioned, and obviously the registered population is 340,000, which I think is a number just to hold in your mind for a second. I think I'm pressing the wrong button. So to provide some data, so this is the data from national sources that's collected around the number of GP appointments that are provided. And when I say GP appointments, I'm talking about the total appointments provided within a GP practice, not just those by GPs. And you can see that in that top left graph that the number of appointments varies through the year. That's the number of appointments provided in Northumberland, and it's gone up. So we've gone up, there was 181,000 provided in 2022-23, and that went up by 7,000 a month in 2023-24. So the number of appointments is increasing over time. I think the bit that strikes me when I look at these numbers is, so we've got a population of 340,000, but 188,000 people are seeing or having contact with their practice every month. So that's a huge element of, or proportion of our population in Northumberland is having contact. So obviously some people will be contacting it multiple times. It's not 188 individual people, but that's still a huge number of contacts for our population on a monthly basis. And that graph at the bottom right shows a bit of a comparison, shows the appointment rate per 100,000 in Northumberland, which is the blue line, which is the one at the top, across our ICB, which is the North East and North Cumbria in orange, and then in England in grey. So we can see that comparatively in Northumberland, more appointments are being provided than in the North East on a monthly basis, and than in England. These next just show some of that. So we know there's more appointments being provided in the North East, but we know there's variation within that. So this highlights some of that variation. So the dotted lines are the kind of the maximum and the minimum practice. So you can see there's quite a swing there in the rate of appointments, and the bar graph shows that range. Now, some of that is expected variation. Some practices provide 10-minute appointments, some practices provide 15-minute appointments. If you're providing 10-minute appointments, you're going to provide more per day. That's just in the way it's counted. But some of that is unexplained variation, and that's where we need to try and improve things. If we look at how those appointments are split, roughly 43% of our appointments are provided by a GP, and 54% are provided by other practice staff. So this could be nurses, this could be advanced practitioners, this could be physios, this could be healthcare assistants. That's changing over time. So if you go back a number of years, that would have been predominantly GPs. We know there's been challenges around recruitment of GPs and training of GPs, and therefore there's been an increase in the wider team of clinical staff to be able to try and meet that demand. And the graph on the pie chart on the right shows what that proportion is of how patients are accessing. So around 70% of appointments are face-to-face, 24% are telephone, and we have a small number are home visit and a small number are done through video calls. That 70% is high, so the England average is around 67% for face-to-face appointments. Showing that as a comparison, you can see that that grey line is England for face-to-face appointments. The dark blue line is Northumberland, which is slightly lower than the North East and North Cumbria, and it's on a slightly downward trend, so the number of face-to-face appointments is decreasing, which isn't unsurprising considering the direction of travel for general practice, and I'll talk a bit around some of the change in models and access approaches in a little bit. You can see on the graph in the bottom right, which just shows our ICB, that the three of the areas towards the bottom, we've got County Durham, Northumberland and North Cumbria, all our rural areas. So it's unsurprising, I think, that you have more telephone or kind of video consultations in the more remote areas. These graphs show kind of how long patients are waiting to be seen. So by and large, most patients get seen on the same day. We have a small number fall over to one day, and then you start getting into your routine appointments, so your people who call back for less urgent complaints. If you look across that, we've got Northumberland, our ICB in England, and you see the profiles roughly similar. There's not a huge discrepancy between how those are looking. In Northumberland, there's slightly less same-day appointments than kind of in other areas. So there's a lot of comparatively positive things in there, wasn't there, around kind of there's more appointments being provided, in terms of there's more face-to-face appointments being provided, which I think a lot of people prefer. But we know that there's still lots of challenges. We get contacted as an ICB quite regularly around people who are struggling to access services, and I'm sure members will too. This data is from the National GP Patient Survey. It's our 2024 results. So these were collected between January and March. And you can see here, I've picked out some questions from that survey which might be of interest. So the percentage of patients surveyed who find it easy to contact their practice. So we're slightly higher in Northumberland than the national average, but it's 50%. So that's 1 in 2 people are saying that they struggle in terms of contacting their practice. And we can see that range is huge. So it goes from some practices where people, it's 13% are saying they find it easy, to some that say nearly everyone find it easy. In terms of the helpfulness of receptionists, which again is something that comes through quite a lot from patients, it's 86% are happy with the receptionists in Northumberland versus an 85% in the ICB and a national average of 83%. In terms of waiting, how long you wait for your appointment, again in Northumberland, comparatively comes out relatively well compared to the national average, but it's still 1 in 4 patients aren't happy in terms of how long they have to wait. In terms of the overall satisfaction, in terms of with their practice, 78% in Northumberland are saying that they're really happy with their practice versus 74% nationally. So slightly better than the national, but again, there's a lot in there, isn't there, which says, I don't think we can say that's good. There's a lot in there that says there's a lot more work to do. So what are some of the challenges in terms of access? So we know there are access issues around capacity. Are we able to get enough staff and employ enough staff to be able to see everyone we need to see? And there's been challenges around access to new GPs coming through training over time, and that's kind of come to a point now where there seems to be more GPs coming through, which is positive. But can we keep them and can we retain them? There's higher rates of start sickness at any time when there's lots of challenges, and it's a very difficult environment to be working in. There's a lot of stress in the system. Quite a lot of practices are limited by the size of their building, so they want to increase and they want to employ more people, but they just physically haven't got space to be able to do that, and that's a challenge that we need to try and address. There are still a number of wasted appointments where patients book in and don't turn up in DNAs, and can we find a way to reduce that into an acceptable level that's manageable? And the other thing to highlight is there's a current GP collective action underway where the British Medical Association and there's a feeling within them and with a number of practices that over time there's been underinvestment into general practice, and there's been a shift of work that's been unfunded into general practice, and that's got to a point where they're no longer happy with that. And so there are actions that practices are taking collectively to kind of push back against that. They're not employed by the NHS, so they can't strike in the same way that junior doctors and consultants did, but they are looking at what action that they can take as practices, and some of that action will result in a reduction in capacity within the local system. It's not got a huge impact currently locally, but something to monitor. So there's some issues around capacity. We also know that the number of people who want to access services is increasing. There's a huge current same-day demand that comes through, and a lot of people have seen that through the 8 a.m. rush and through people struggling to get through on the phones. There are impacts from the difficulties post-COVID in secondary care organisations where we've got very long waiting lists for some operations. And if you're waiting to be seen, you often will still need to see someone medical, you'll need medication, you'll need support for pain relief, and that has increased appointments in general practice as a result of that, just to try and manage the ongoing needs of patients who are waiting for their operations. We know the demographic change is there's an increase in age and over time, and that's increasing. And as you get older, you need to access healthcare services more, and you have more multiple comorbidities, and you need more polypharmacy, and that takes more time within healthcare to manage. So within the demand, so there's more people needing to be seen, but there's also a greater number of times that they would need to be seen. We do get some spikes when there's some public health concerns. So, for example, around kind of monkeypox or around the strep A, when there's some fear in the general population, there's a lot of contact that goes through general practice to try and get reassurance around that, and that just adds to the demand on phone systems particularly. And as with any service, if you have effectively a waiting list, then that creates more work because people will continue to contact you till they've got an appointment. So there's increased call waiting times, and if you have people have to phone back the next day, then that increases the number of people who call in the next day, and that soon escalates. So that's some of the access challenges around capacity and demand. There's also increased patient expectations, so we're a lot more aware of our own health. There's a lot more information online, and we want to be more involved in our own healthcare. And that takes more time in terms of supporting people to be able to do that. There's frustrations from members of the public who aren't able to get appointments, often justified, and that will lead to complaints. But those complaints then need to take time to manage and to deal with. And there's a significant increase in the levels of abuse that has been provided to practice staff as a result of difficulties around access. Technology is one of the solutions that's been put forward to support some of the access challenges, but the NHS isn't great with technology. It's generally quite a long way behind the curve. So we've got a number of practices that had outdated telephony systems that can't manage the demand that's going through them. Most practice websites could do a lot of work. If you think of if you wanted to go and look something up now, you would probably go online and go and find something out. And actually, general practice websites don't often give a lot of information or up-to-date information. And we saw that quite a lot with the COVID vaccinations, where there was a lot of telephone or people wanting more information, and they would have normally just gone to a website and got it, and they weren't able to. And then there's some challenges around the triage models that the technology is pushing people before, and how comfortable they are with those triage models and able to use them. And we've got there's concerns around the digital maturity of our population. So some people will be great at accessing services through online or through other mediums. Some will really struggle with that, and how do we support them to do that? And there's a clear inequality there between patients who are able to access kind of Wi-Fi or have data on their phone and those who haven't, and how do we manage those? So those all, our direction of travel is to more technology. How do we manage those challenges? So that's kind of an overview of some of the challenges that practices in us as a system have. Just to talk about some of the things that we're doing as a health service. So on the 9th of May last year, the Primary Care Access Recovery Plan was published. So there's 3 recovery plans. One's for elective care, one's for urgent care, one's for primary care. And the ambitions of this are really to tackle that 8 a.m. rush and to reduce that number of people who are struggling to get through to their practice. And for people to know that when they contact their practices, that their request is going to be managed that day. So they're not easy. They're very definitely an ambition. They're not easy to meet. But the 4 key areas that we're focusing on to do that are around empowering our patients. So can we provide them with more information in a way that they can digest? And the NHS app, and some people might use the NHS app, is going to be, I think, a key tool in the future in terms of that communication with your practice and how we provide information to them, and how you have access to your record and can see what's happening. Can we increase self-directed care? So there are a number of pathways where we're saying, actually, you could just self-refer yourself. You don't need to go to a GP to get that referral. And if you're able to self-refer, then that will save some of the work that's currently going through a practice where you would go and see them and they would just refer you straight away. And you may also have seen some things in the news around pharmacy first. So there's a work programme to expand the provision in community pharmacy for minor illnesses. Again, the idea being that will shift some of the activity away from practices that are struggling to be seen in community pharmacy. So that's how we're trying to empower patients to do something a little bit differently. I'll talk a little bit about modern general practice in a minute, but effectively that's saying, can we provide better equipment for when you contact your practice so that you can get dealt with and they have the systems to deal with that? Can we do that through online mechanisms as well, so that if you have a number of people using an online mechanism, that frees up the phone lines for those who can't use an online mechanism? And can we triage and navigate people to the right place quicker? So rather than seeing multiple people before you get to the right place, can we cut that out and get you through to the correct place? We know we need to get more people. So there's a big process through primary care networks around additional roles, and there's quite a significant investment into that. So that's increasing the workforce. It's not a GP workforce. There's been some new funding announced recently, which will increase for newly qualified GPs. But most of those are physios, pharmacists, and paramedics, and kind of some advanced practitioners. There's increased training of doctors that's going on the way to try and increase the number that we have available of GPs. And there's some programs around supporting the return and retention of GPs into the system. And there's a program of work to increase the contributions that are made to support the development of healthcare infrastructure through housing developments, for example. So working with councils around Section 106 or community infrastructure levy, depending on what's in place, to ensure that there's support there where there's an increase in population for the healthcare services. And some councils are very good at that, some councils are less good at making those provisions. And the last one is around, can we reduce some of the bureaucracy? So there's lots of things that GP practices are having to do which aren't clinical, around how they work with secondary care and the bouncing of patients between them, and how they're managed in a more effective and streamlined way, but also in terms of the things around sick notes and around insurance, etc., around certain licenses that are needed, that you go to your GP to get those currently, and that's taken them away from some of their clinical work. So can we find ways to support that? So this is the modern general practice model. I don't know if it might be a bit too small to read. I don't know if that's available. But effectively, this is around saying, currently, lots of people try and access their practice in lots of different ways. And at the minute, it's almost a first come, first serve. That if you get through on the phone and you get your appointment, then you're there. Regardless of how much need you have, that's the way it works. And that's not the best way to be providing services. So we need to have a mechanism by which we can look at all the patients who are trying to access and go, these are the ones who really need to be seen today, and these are the urgent ones, and we'll see them first. These are the people who could be seen in a few days because it's a minor illness, and we can triage and manage that effectively. And that's what this model's effectively saying. Is there a way of pulling together that information that comes through the phone, comes in online, or comes in for people walking in into one collective pool that we can then review, look at that and decide how best to treat the people that are there. And some of that might be you need to see a GP, some of that might be you need to see a pharmacist, some of that might be you'd be better off going to your community pharmacy and be seen quicker, some of that might be social prescribing, some of that may be care navigation to an alternative route. But how do we pull that information, and how do we put a model in place in a practice to allow them to do that? And that's quite a big change for a lot of practices, and it's not something that's going to happen overnight, and it's something that's going to need work to get it right as well. Every practice works in a slightly different way. They've got different numbers of staff based on their size. They've got, as I said, different size buildings, so it's not one model fits all, unfortunately. And some will be better at making these adjustments and quicker at doing it than others. So this is going to something that takes time, but this is the direction of travel that we're moving practices towards. And some have started to do that. The key bit of that is going to be how that's disseminated to patients who are accessing that service. When there's any change, we can spend a lot of time getting the practices lined up and understand the staff in there knowing what to do, but there will be change here for patients in the way that they access services. So some practices are moving to this model, and the easiest way to do that triage and get all that information on all the patients who are trying to access them is to everyone to access through the same route. Now that may be an online system that needs to do, and they need to put in place the mechanisms to manage the people who can't access it in that way. And there's lots of challenges in how best to do that. And quite a lot of the patient feedback and complaints and concerns and issues that we receive are around changes to the practice model that they provide their service. And it's very hard to have there's no perfect model that's going to work for everyone, but this is the theory and the reasons behind why that's changing, so that we can make sure we're seeing the right people the quickest. So a little bit around progress to date. So now in Northumberland, most of our practices have cloud-based telephony, so that's something that works off cloud somewhere, not technological, but that provides a lot more information on the demand and the people that are accessing their services, and it has more functionality than your standard telephone system. So a lot of them have systems whereby you will phone up and there may be a queue, and it will say to you, you're number 5 in the queue, we will call you back when it gets to your slot. So you don't have to stay on the phone for ages, and you don't have to try and spend ages ringing. Some systems are better than others, and it's practice choice which ones they use, so it's not a uniform. And obviously there's an element of learning how best to use that system. I've got a mobile phone, I think I use 2% of it probably, so it takes time, doesn't it, to learn and adjust to a new system. We've got a number of practices trialling that modern general practice access model and moving to that full triage, and we'll get the learning from that, and that will help us with how do we spread that and how do we reduce some of the pain where that's working in other practices. We've got across the ICB, we've got a digital support team that's helping practices make some of these adjustments, so that can help them with their website, can help them with understanding their cloud-based telephony. There's a lot of online consultation systems that are being used. So how do you best integrate that into how you work as a practice so that it feels seamless rather than just a bolt-on? Our PCNs are maximising the funding that gets the additional roles. So we've got 195 additional staff employed through that across Northumberland currently. Our practices, our PCNs all submitted their capacity and access improvement plans. So there was some funding that went to PCNs to say, how can access be improved in your area? And they've been working collectively, collaboratively on the bits that they think will make a difference for those. We have recently identified funding and commissioned some acute respiratory hubs for winter. So this is for patients where you get a lot of respiratory illness, colds, coughs, etc. So this will be some additional capacity to support over the winter months. We have a number of estates projects going on, but we've got 3 practices that are in the process of relocating to buildings that will be much more modern and better suited to modern general practice, but also have more space so they can see more people. We've undertaken quite a significant programme across all of our estate where possible to say where, for example, records have been moved online, can we convert that space into consultant space? Can we increase the space within existing buildings? This is just some info around workforce. I think if we think about kind of access, we can either try and make what we're doing bigger, can't we, or we can try and make it more efficient if we want to see more people. And I thought it would just be useful to have some, so you've got some visibility and some data around what's happening in terms of the workforce. So this just shows over time for the different work groups. We've got all staff, we've got GPs, nurses, direct patient care and admin. And as you can see, all those numbers are increasing. We had a big dip in GPs a while back, but that's on the up and we've now got a higher level. If we look at that comparatively, in Northumberland, the middle graph at the top shows, so this is across our ICB and in England, that there's more GPs per 1,000 population in Northumberland than across the rest of the North East, and actually across kind of England on average. And there's more staff than England per 1,000 population across all of those staff groups. The worry we have currently is around nurses, which is the one on the right that's a little bit lower, and kind of the age profile of nurses to make sure we've got some coming through. And this was just, again, to just a bit of context. So this shows the trend in the number and the size of GP practices. So GP practices, the numbers are decreasing over time. It's quite hard in general practice now. This is why there's unrest. They're struggling to make ends meet, and when that happens, kind of practices will close or shut, or we'll need to take them over. And we've been good at that, I would say, in Northumberland, but the numbers still decreasing and the list size are increasing. So smaller practices where we have them are more of a concern, and this graph shows those list sizes kind of against the average, and you can see that the number that are below that orange line, we've got a lot of practices in Northumberland that are below the average now. And that's something we need to monitor, ensure they're resilient and sustainable, but there's a risk there. Similarly, if we're talking about demographics, this shows the projected increase, kind of the current increase and the projected increase in the over 60 population. And you can see it's increased by 26% in the last 10 years. And as I said before, we know as you get older, you need more healthcare. That's just one of the facts. And it's going to increase by another 14% over the next 10 years. So there's an increase. The level of demand is unlikely to go down, is what this is saying. And we need to be in a position where we can try and manage that. And I think that's it. So happy to hand over to any questions.
Okay. Let's see. Councillor Ball, straight away with a question now.
Thanks, Chair. And can I just apologise for my lateness? I got caught in traffic on my way in. So it seems like there's a massive amount of appointments when you say 188,000. Is that actual face-to-face doctor's appointments, or does that include things, because a lot of doctors are doing community sessions and weight loss groups and mum and baby, so is it contacts or actually face-to-face appointment? And the other thing that I wanted to just touch on is, with everything going fully digital, some of the cyber risks, which I know we've seen previously where a system's been attacked and people haven't been able to get appointments for days. How is that being managed? Because if we are going more and more online, digital and everything else, how are we making sure that if something does happen, that whether you're working across different practices to make sure that you've got a backup plan as well. Thank you.
Yeah, so the appointments there are all appointments within the practice, so they're not just GP appointments. There'll be some nurse appointments in there, there'll be some HCA appointments, for example, but it will be appointments that are delivering their core contract. So it's not going to be some community stuff on the side, for example. Around 70% of those are face-to-face. So there's a proportion that are on the telephone, and I mentioned that the number of face-to-face is going down. I think that's because the number of triage appointments that are done by telephone is increasing, or the number of appointments that follow an online consultation that's picked up over the phone is increasing. So I think that is a bit of a trend, that there will be kind of a shift away from... most people would still like to go to see their GP, so I don't think it's ever going to be a minority, but the total appointments shown there are actual contacts within the practice. For medical reasons. Yeah. So it's a huge number. It shows the demand. And in terms of the cyber stuff, so each practice has a business continuity plan in terms of how they will manage if they lose their systems. And that's for them as their contractor to manage. In terms of the GPIT programme, that's managed within the ICB and through our commissioning support programme. There's quite robust processes in place around how to manage when there's outages. But there are still some challenges. So some of it may be a system supplier issue, in which case that's kind of the next level up, and how do we manage. So there's processes to look at cybersecurity across the network, but ultimately if something goes wrong that you can't just for, and the practice has a plan on how they would manage that outage. Yeah, it's a risk, isn't it? Because we're more and more digital everything.
Councillor Hunter.
Thank you, Chair. Thank you for that information. It's very interesting. I appreciate the telephony, if we can move that forward, because again, if you get people that keep dialing in and that, they get, after maybe 10 minutes, quarter of an hour, half an hour, they get frustrated, and unfortunately the receptionist gets it at the end. So that if they get your call and we'll call you back. Also, hopefully increasing the telephony appointments, because if somebody's working, that means they don't have to take time off work if they're still fit enough to work, but allowing more face-to-face ones, because there's some people still don't like that. They like the old-fashioned way, but it's how are you managing the communication to patients to say you don't always have to see a doctor. That could be, a practice nurse or somebody that's within that practice that could look at it, because a lot of people still think if I need an appointment, it's a doctor, and that they're being put to the side if they've been offered somebody else. So it's how are you managing that communication?
Yeah, and patient education is a really important thing here, isn't it? In terms of as we change our systems, how do we bring people with us? And there's from my experience, what I've found is there's patients who access their practice very frequently. So they've got health conditions and they're very knowledgeable. And then there's a bigger proportion of the population who maybe go to their practice once a year or once every few years. And the level of contact there is a lot less. So it's quite hard to provide them with the information, because your initial thought is, I need to go and see my doctor, because that's what I've always done. So it's really challenging. And what you will probably find when you contact your practices, they're moving kind of away from kind of receptionists into this care navigation model of having someone who will direct you to the best point of care. And we're always very keen to work with kind of partners, and we've been doing some stuff around health literacy, for example, and supporting practices with their health literacy and the information they're providing to patients so that it can be understood. And we work with Health Watch to provide the information in a way that we feel that patients will understand it. But it's such a broad, isn't it, part of the population to usually have one main method of correspondence. So, it's challenging to get it in a way that everyone understands.
Just to add to that, I think we are doing more in terms of triaging that initial contact. So if patients contact, as you say, they may think they need to see a GP, but given that there's a wider team now, there's the practice nurse and maybe an AMP, and some of those staff are better skilled at managing long-term conditions. We now have physios embedded into practices through these additional roles that James was referring to through the PCNs. There's also mental health practitioners. So often they might be triaged at the very first point of contact and say not for a GP, but to go and see that particular staff. I think we have a wider team now in primary care than we certainly used to.
Yeah.
And that makes for efficient service, because as you say, you then free up GP appointments for those who actually need them. So, but it is a work in progress.
I think from my experience, the experience of seeing someone who's not a GP is usually quite positive for most patients I've spoke to, and it's almost you gain it through experience. Almost you go to your practice, you see a nurse, you're happy with that. I could see a nurse the next time.
Right, I do have Councillor Nisbet and Councillor Seymour, but I did see Derry Nugent from Health Watch had a hand up, and also Veronica Jones as a cabinet member. So I'm going to bring Derry and then Veronica Jones in, and then I'll come back to the councillors. So, because I expect they might be related points to what's been said. So, Derry.
Thank you very much. Excuse me. I think that was a really great summary of the challenges and everything that's facing general practice. I think, as you know from conversations that we've had, that patient experience tells a very different story, and I think that is what you're hearing from elected members. So those of us who are out every day hearing from patients, including general practice staff, do know that patient experience is differently reported. I think there were a couple of points that I would say around that. Is that on your presentation you had patient involvement as both a challenge and a solution. And I'm not quite sure how that sits with it, and I think that might be, or it may have been the terminology that you used. But I think if you are thinking that, you know, some of this and about the making the understanding of what general practice is trying to achieve more readily understood, then patient involvement is absolutely got to be there. And when you're talking about the trial of the Modern General Practice Access project, I presume the assessment of that will include some patient feedback, and you will get, is that going to be part of assessing how the trial has gone?
Yes, so it's a national model. There's not a here's how you must do it. So each practices are doing it in a way that ones are doing it in a way that works for them. And there's been a couple of practices that have changed and are doing that on the basis of some of the feedback they've had from their patients. So it's very much a feedback loop into there.
Which I think is the main point, isn't it? Because I think one of the things that we find around access is sometimes there is a lack of flexibility, because a lot of what you've had up there is about national guidelines and national targets, and it's about where that local perspective and reacting to local circumstances. And I think I was very taken by one of the last points you made, where you said that some, you know, navigating primary care for someone who doesn't use services is sometimes the most difficult. And I think about, you know, when we think about people who might not use services, and we know that by, you know, there is a tendency sometimes for men not to have used primary care services as much. You know, we've got to think about communication, and we've got to think about involvement if we want those people to understand. And what I didn't see in some of this was that equalities issue written quite as large as I would like to see it. We know from the feedback that we get that digital, well, I think you've said it in your report, but I think the digital stuff is not the answer for some people, because it's just not going to work. And sometimes, again, I come back to that flexibility. So, you know, I think if all of you will have received our report, our monthly report, where we had an experience of a gentleman standing in a practice being told to go away and make an appointment online, and someone saying to them, well, your phone can do it, just go away and do it. Now, that I don't think with any shape or form that is what the service is you think people should be getting. And that, for me, was a straightforward equality issue. Yeah. And I think that's why I'd like to see some of the equality issues in Northumberland written slightly larger in this. My final point is if you've not already seen it, there's a report that we've got copies of here, which has come out from Ipsos in the last few days, which talks about the fact that some of the things you've been talking about in terms of resources and patient list sizes and all of those things are the context for some of these improvements. But actually, some of the things that can create the greatest improvement in some of this are things which are within the gift of practices. They don't rely on these contextual issues. And I just wonder how, this is my final question for you, I think, is how you are bringing all the disparate players in this together to focus on those bringing forward the best and learning from the best examples of where things have changed locally that can be then spread out.
Yeah, and certainly that primary care network, kind of we've now got, when we look at our geographies, we've got Northumberland and then we've got neighbourhoods within Northumberland where there's much more collaboration between practices than there ever has been before. And if you go back 10 years, because practices are almost in competition to some degree because their income is based on the number of patients they've got. So if I take 100 patients from a practice down the road, that increased my income. And that was historically how that worked. There wasn't a huge amount of interaction between some practices. Some places, they all got very well. So primary care networks has really driven some of that collaboration and sharing and thinking about actually, is there a better way of doing that? And we've got a network of primary care networks within Northumberland that meets on a monthly basis and we have workshops with, etc. So we've got those mechanisms to share and the kind of across the ICB, that digital support team that I mentioned is working across the ICB and a lot of their focus has been on this triage. And there's some real tensions in what you said around if you want that triage to be the most effective, you kind of want most people to use one route, but most people don't want to all use the same route. And there's a real tension there between how do you kind of cut across. And there's quite a bit of evidence that says with those triage models, if you have lots of different if you kind of need to do it or not do it, and if you're kind of halfway in the middle, that can sometimes be worse. And I think for some of our practices, they're potentially finding that out now, in that you kind of trying to manage too many different ways of doing things. So totally take on board your points. Certainly, in terms of that models of access, it's pushing towards that triage and kind of one way of kind of doing things. But my personal fear is when you do that, it will work probably for 90% of people, maybe even 95% of people, but it's the people it doesn't work for that just fall then through the gaps. And there's quite a lot of experiences with that with secondary care when they put in processes. And we don't want to repeat that, so that's definitely something that's on our agenda.
I think we've probably left that a lot down to individual practices to sort of flex that model really. And as you say, I mean, you know, for example, when James was talking about, well, 70% of contacts are face-to-face, I don't know if that's good or bad, and I don't think that's what we're saying, because, for example, I work in a very rural practice, and that, you know, we need to offer remote access for patients who might have to travel half an hour, 45 minutes to come to my practice, whereas in more urban practices, you know, that face-to-face can be a little bit more easy to access. And then you've got changes in the demographics of a practice, older patients who would struggle to access, you know, for example, the e-consult, which is the online way of seeking advice from practices. So I suppose we've sort of left it a little bit for...
But I think that in terms of the models, but the other thing I probably should have said is we have invested in kind of some population health work within our primary care networks, and they are looking at some of those harder to reach groups. So we've got Farm Fit in the north and in the west, where they go into the farmers market to pick up the people who just in their working day wouldn't usually be able to go, and they're looking at children. There's a huge range in terms of what they're looking at, but trying to identify their local populations that access isn't as good for.
And there's also the extended access that James referred to as well. So there's lots more appointments now on Saturday in lots of hubs right across Northumberland as well, which for working people is great as well. So. But yeah, the access into, for example, the farmers' market, into the fishermen, is those who wouldn't come, and it's not that they struggle to come. They don't want to come, to actually just kind of get there and trying to screen them for sort of health conditions is really important for sort of preventative medicine.
Right, Councillor Jones, and then I'll return to the members.
Thank you, Chair. And I was actually waiting till all the councillors on the committee had...
I realised I got that wrong.
Thank you. Yes, two or three things, so I hope you'll just bear with me. To be honest, your survey results, particularly on sort of survey satisfaction results, particularly on things like appointments, didn't really match what we're picking up. that there's a much higher level of dissatisfaction than your tables were showing. And I hope you don't mind me saying this, because when you were giving us the report, to me it almost sounded a bit like you were blaming the patients, and I'm sure you weren't, but it did come over like that, you know, didn't know the system, perhaps did it wrong, that kind of thing. You actually said that there's an increased demand for same-day access for appointments, whereas many practices, and mine's one of them, you can only have a same-day appointment. You can't say, can I come in tomorrow, can I come in next week? It's got to be, you ring at 8 o'clock in the morning. And again, you said about essential services within core hours, 8:30 till 6:30. Well, in actual fact, in reality, GP appointments are only available if you're available between 8 o'clock and approximately 8:20, which is when the message changes to there are no more routine appointments for today. So those essential services are only available for people who can do 8 till, again, roughly 8:20. And that leads me to parents, carers, because 8 o'clock is about the worst possible time for parents when they're getting the children ready for school to hang on to a phone for 20 minutes, to be told you're 10th, 20th in the queue. So really, to me, that it'd be much better if they could make those appointments be from 9 o'clock. You know, no, that gives them a chance to get home from school. You know, there should be different bits during the day that all ring at 9, 8 o'clock and sit there. Apart from tying up the lines, if you're told you're 20th in the queue, does that not tie up all the lines? So those are my concerns about the appointment system. And just one more about triaging, and I think triaging's right. The bigger practices have got pharmacies, they've got physio, they've got all sorts, right? So that's right. But the message always says, you know, our staff are confidential, right? And that's good. But how much of an ability do the staff have who are answering the phone to decide what's right? So that worries me slightly. And particularly, and I've come across this, do the staff, and I hope you'll tell me this should be the case, get access to the patient's record before they triage them? Because I've come across, you know, ones where it's been, no, it's a minor one, go to the pharmacy without asking who they are or anything about them. So I'm hoping you'll tell me that was a one-off. That was my list, Chair. Thank you.
Okay, Frank, do you want to address any of that, or do you want to address that at the end?
I'm happy to.
Right, okay, well, what I'll do is I'll take our last 2 points. I don't think anyone else wishes to speak. Then we'll let you sum up, and then I'll sum up as the chair. So, Councillor Nisbet. Okay.
Straightforward one, really. It's just about, there's 188,000 in Northumberland appointments. Is that right, what you said? Yeah. How many missed appointments from people that just haven't bothered to turn up or haven't cancelled? So how many patients have just not bothered going?
So it's varies obviously per practice. It's usually between 3 and 10%.
Sorry?
So it can be between 3 and 10%.
Really?
Yeah. So obviously we want that to be as low as possible, don't we? Because otherwise it's people missing appointments. And part of the technology stuff that we're trying to encourage practices to have, so some have text, so they remind you of your appointment. Part of the challenge comes back to the telephony thing. That if you want to cancel your appointment, how easy is it to cancel your appointment?
Yeah.
And can you get through on the phone to do that? And sometimes that's really hard. And that puts you off, doesn't it? Because I can't stay on the phone for an hour to cancel an appointment. So we need to have mechanisms in place which allow people to do that.
Mm-hmm. The problem I've got is when, you know, you're talking about, you'll get a text message, I do. But how many people haven't got phones? How many people, you know, especially in the elderly population that don't access digital, they don't access online or anything like that. They're the people that I worry about, because how do they get that support? You know?
Yeah. I'll just add to that. It's not only not having a phone, because most people will have a phone. I know some people won't, but most will. But it's also, if you're sat in this building, for example, and you're waiting for you're not going to get a text message, are you? So even if you got your phone, you can't get it. But anyway,
so it depends on.
I butted in, sorry, but
depends on the clinician. Some roles have a higher proportion of DNAs than others. GPs is probably a bit lower. But yeah.
Councillor Seymour.
Yes, thank you, Chair. Actually, that was my question. I just wondered what the how many appointments weren't attended. And I suppose now that you know, there is this system where you can, there's a reminder. It's probably improved a lot since, so 3 to 10%, but that's still quite a lot. Where I live, up in Berwick, we have a minor injuries unit in the hospital, and so people tend to go there if they can't get an appointment. And usually it's quite good. It's not busy in there usually. So I don't think people like to go there, but if they feel that something's not quite right and they need to see a doctor and they can't see them at the surgery, then they go there, and it's open 7 days a week. A lot of residents are quite frustrated really that they can't see a doctor. And I suppose I'm going back to years ago when they used to be walking, you used to be able to go to your GP and just go, not make an appointment, and just wait in the room, if you like, until your turn for the walking clinics. And I know they have them in other countries still. And I suppose, I don't know in this country if we still have any that you can just go to. I don't, maybe in London, but I don't know of any up here unless you go into the hospitals and just go into their minor injury units.
Yes, so do you mean like a walk-in centre? Is that what you're referring to? So a lot of those are now booked appointments, so rather than having to wait, so a lot of the urgent care or minor injuries places have, you get a booked appointment through 111. It's quite a regular mechanism, so you don't have to go and sit somewhere with a lot of ill people for ages. You just go in when it's your time to go in.
But in Northumberland, is that sort of at Cramlington or Wansbeck or?
So all urgent care is usually you can walk in, but some of them now will say, here we'll book you an appointment, you can come back or you can wait. Some of them where it's kind of an A&E urgent service, you would just wait, as you might do in the minor injuries unit in Berwick. Certainly I'm more of a primary care, so I know the practices I'm less, have less awareness of the urgent care system.
Mm-hmm. Okay.
Got Councillor Richardson, and then I've got Councillor Patterson, and then we probably do need to make progress.
Yeah, just about the telephone calls. I mean, some of my residents were saying to me that they had phoned 8 o'clock in the morning, hold, and when they got through, sorry, we're fully booked the day, try tomorrow. They did the same the next day, got up 8 o'clock, phone, sorry, we're fully booked, try the next day. And I don't think it's right that every day keep trying. One person had gone down to the surgery, to the doctors, and said, could I get to see the doctor? Oh, we're fully booked. Go home, try ringing in the morning. But when they do, they're just getting told, we're fully booked, try the next day. So that's what I'm concerned about, the elderly that are phoning every morning.
Yeah, and that is a real concern, isn't it? Because your condition can escalate over a number of days. So while on the first day you might have been a little bit ill, by the 5th day you're then very ill. And that's where some of this kind of policy direction is trying to resolve. So there's a requirement now, practices, if you do speak to them, that they're supposed to either sort you out on that day or direct you to an alternative service. Now sometimes that may be in minor illness or minor injuries unit or something, that may be because they're saying they haven't got capacity, but it's removing the risk from that escalation for that individual person. And certainly that's the telephone issue and the telephone issues you've raised. If you look at that data, 50% struggle to get through to their practice on the phone. So that's 1 in 2 are saying they have real problems. So that's why we're aware of that, and we need to try and address that. And that's where the cloud-based telephony is, where some of the change in the access models are aimed to try and improve. And that's that ambition to remove that 8 AM rush. But it's very challenging. It's not an easy solution, fortunately.
I would have thought the better idea if you phoned and they're saying we're fully booked the day, but you've got the next appointment for the next day, and so on and so on. So they definitely know they're going to get an appointment the next day. And the ones that phone the next day, they'll not get one that day, but they might get one the next day. You know what I mean? That's how I thought it should work.
I think there is a change though, and that's because part of this, because I recognise that problem you're describing, and that's and it's sort of multifaceted, isn't it? And how, you know, different. It's going to take different solutions, but there is that recognition that going forward that if patients have to be answered within a certain time and given a plan in terms of when they will be assessed, and whether that's today or at a later time, or seeing a different health practitioner. And I suppose that's the advantages of triage as well, because as you say, it's not always a GP, even though a patient might perceive they need to see a GP, actually probably better to see a nurse or physio, etc. But I think what you're describing very clearly are the real challenges, and it's just how they can be addressed. You know, and there's capacity, there's problems with estates in terms of, actual just number of rooms to put some of these other health practitioners, because I certainly know, so in my practice we're very lucky with space, so we can have a physio, we can have a pharmacist, etc. But some practices don't have that space for, and that limits the sort of appointments they can offer. So there are so many challenges that do need addressing, and certainly some of the stuff that James has described today is the start of that journey. But I don't think we're for one moment thinking it's completed at all. And you can see how, for example, the number of appointments has risen, but also demand has risen as well. So it's how you can keep pace really with that. But it is a challenge.
Councillor Patson.
Couple of things. I just touch a little bit on what Councillor Seymour said. I remember being taken as a child to the surgery, and we waited a long time, but you did get seen that day. I mean, 2, 3, 4 hours, I can remember that. Then we went to an appointment system, which was great. Everybody was happy, get an appointment. And then this happened where you can't get an appointment. And it's trying to understand what went wrong. And is it because there is no GPs? Is it because we as a public are more demanding? Or is it because we're living longer? What is the reason for that? Why all of a sudden is it difficult to get a doctor's appointment?
So I don't think there's an easy kind of it's down to one specific thing. There's lots of kind of multifaceted factors that are impacting this in terms of kind of the availability of workforce, the availability for some practices to increase their size, the funding that's available that allows a practice to employ more people, to see more, the use of technology and the ability to use technology. But I think if you look at the usage of NHS services over time, they are increasing, and a lot of that has to be driven by our demographics. I think the issue is that our system hasn't grown at a pace that allows us to manage that.
Right. The second question is the 111 service. Some of the complaints I received was because people couldn't get an appointment, they were being told to ring 111. And after they'd rang 111, depending on what was wrong with them, they were given a doctor's appointment in the afternoon. So obviously the surgeries must have been keeping 111 appointments free. So it's just trying to understand that, and the 111 service itself, what exactly does that entail? Is that a fallback at 9 o'clock at night when you can't get a doctor? Or is that a fallback for the doctor's surgery who don't have enough capacity to deal with their patients? So where does that service fit in?
So I think 111 was brought in as a deflection was from 999, where people were ringing around some health issues. So it's there to support people with their health, to direct them through the system. It's a national contract for general practice, and within that national contract there's a requirement to hold a small number of practice appointments each day for 111. So if a patient calls 111, they go through a triage process, and the outcome might be you need to go and be seen in general practice. So there was an ask that every practice holds a small number. Now, some hold them at different times in the day. It wasn't you had to have them at certain points. Some have them earlier so they can release them if they're not kind of used by 111, and they're then free for kind of patients calling up to use. But there is provision within that contract, and it's a very small number. I think it's one appointment per 3,000 patients, something along those lines. So it's not a huge number per day that are kind of ring-fenced for that.
And very finally, sorry Chair, just finally, self-referral. Can you talk a little bit more about that? I mean, is it for someone with, say, a funny mole or something? Do you do that then? Or is it oh, I think I've got a really bad chest infection, I think there's something wrong with my lung, can I self-refer for that? So I'd just like to know a little bit more about that.
So there's 7 services that are currently being explored to look at for self-referral that have, I think, evidence-based that they would be appropriate for self-referral. I think the plan is to grow that, but Andy might remember them all, but I'm struggling off the hand. But certainly one of them is MSK. So we've got intermediate physio services and musculoskeletal services. And quite often you'll have a pain, you'll go to the doctor and he'll say, I think you need to see a physio. And then that's not useful of that GP's appointment. You could have just self-referred into that pathway. So there's some things that are on those, but I don't think it will be a high-risk ailment that it would be in that case. It's going to be more along the minor routes.
Yeah, and mental health is one, for example. There's Talking Matters, Northumberland, and that's a self-referral service into it as well. I'm not aware of how many... there's also the conditions that pharmacists can treat as well. So it may be if there's a suspected water infection, uncomplicated water infection, patients can go straight to pharmacists to be treated for that, whereas in the past they would often approach the GP practice. But it isn't, for example, if you've got a suspicious mole that you think might be a cancerous, you can't refer directly to a dermatology. We have specific pathways for that. So, for example, that would always go through primary care.
Yeah. I'm happy to get information and share. It would be useful.
Yes, I think it would be interesting for everyone, really, just to know a little bit more about that. So thank you very much indeed. Thank you.
Right. We've had an hour on that now. So do you need anything to sum up at all? I think you've probably actually well summed up anyway, haven't you? So what I'll do, I'll just sum up as, I mean, as a chairman, we do live in a different world, so it's changing all the time. Some people, really younger generation, for example, don't like talking on the telephone at all. Do I think in 30, 40 years' time whether there'll be many phone calls going in at all? I don't, to be perfectly honest. But we're living in a generation, you know, I'm perhaps in the middle of it. It's perhaps there's a generation before who don't, you know, you don't think of your GP like you're booking your rail tickets or you're booking a football ticket or whatever, that you've got used to doing it in a different way to what you did 20 years ago. I think people see it as a gold-plated service in terms of its importance. So I think that mindset that you go and log on an app, and I get texts all the time saying that my surgery's changing it and what do you think about it? Well, I'm not using it every day. Why should I, you know, how do I know? And, you know, if you're not using it frequently, you know, if you're buying a ticket every day on the train, you get used to the app. If you're not going to the surgery every single, you know, all the time, you're not used to what the app is, if it changes or what have we, or whether your system, even the telephone system changes, you're not used to it because you're not doing it every single day. So there's always going to be issues with that. But I think we've explored the issues quite well there. There's a lot to take in, I think, from what we've said there. Whether we take any further on this, I think we need to look at some of this going forward and perhaps talk about it another time, or what have we, if there's anything we needed to drill down on. But thank you for that very useful presentation. There's a lot for us to consider, a lot for us to take forward. And with that, I think I'll close that item and thank you to everyone who contributed to that. Okay? Thank you. Don't feel you have to say. That's fine. Okay, so I'll go to the next item on the agenda, which is the report of the Cabinet Member for Caring Adults, Complaints, Annual Report 23-24, Adult Social Care and Continuing Healthcare Services. And I will pass over to Councillor Patterson again.
Thank you very much, Chair. Well, it doesn't seem like a year since I sat here and we went through the complaints procedure, but it is. We do take any complaints about adult social care extremely seriously. However, out of 7,000 residents, we have 75 complaints. So it's, you know, as I say, we do take them seriously, and James is going to take us through, James Hillary, our adult social care complaints manager, and he's going to take us through those complaints not individually, I don't think. I think he's just going to touch on them. But it's very important, and some of these complaints were very bad. James?
Thank you, Councillor. Thank you, Chair. My name is James Hillary. I'm the Adult Social Care Complaints Manager, and I've written this year's annual report on complaints, as well as it also includes inquiries and compliments, so other contacts the team might get. The relationship with the NHS is we have an arrangement in place where we can look at some complaints that for people whose care is funded by the NHS. So that's people who might live in a care home or might live in their own home and whose care is funded by the NHS. And if they make a complaint, then it may well come to my particular team. As I said, the report also covers a number of other contacts that we have in any given year from members of the public. And I'll just go through it section by section, and then obviously if you have any questions at the end, I'll do my best to answer them as best I can. So in Section 2 gives us some numbers of complaints that we might get in any given year, complaints we receive and complaints we respond to. Those numbers might vary because some complaints start in one year, the end of one year, and will go into the next year, and so on and so forth. So those numbers don't always align. And similarly, the numbers might vary from year to year. But I think the context, as Councillor Patterson said, is we have in the region of 7,000 service users and in the region of about 2,000 carers. So the numbers of complaints that we get are comparatively small. It's no more than 1% of a locality's caseload that might generate a complaint, if you like. The numbers of CHC complaints are much smaller because the numbers of people whose care is funded by the NHS is proportionately much smaller than those people whose care is on an adult social care contract. In terms of outcomes, we obviously categorise upheld, not upheld, partly upheld, things like that to try and get some notion of whether people have a point or not. And as you can see, Section 2.5, the numbers of upheld complaints have stayed more or less the same for the past couple of years or so. I think the important thing is that about complaints is that people feel they need to make a complaint because their relationship with adult social care or with their care provider perhaps is unsettled, it isn't what it should be. And whether they have a point or not, I suppose, is beside the point. The point is that they feel unhappy enough that making a complaint is important. And a lot of people do find making a complaint a bit of a challenge because it comes with a lot of baggage and you don't want to be seen to make a fuss. So, as I said, it is important, as Councillor Patterson said, to treat everything seriously, regardless of what the outcome might be, because I think the priority is, on one hand, is to put things right if we've got things wrong, and on the other hand, it's to re-establish the relationship that we have with that client and their family, because things have obviously, from their perspective, have gone wrong. Section 2.6 just gives you a notion about the kinds of service areas that are complained about, and proportionally that's about right because adult social care teams are, if you like, the frontline service, so it's not unexpected, shall we say, that they might get the most complaints. Similarly, home safe and independent providers see an awful lot of people as well. So again, that's not an unexpected, I suppose, consequence of the volume of work that they do. There's in section 2.10, for example, there's the kind of themes that might come out of complaints, because each complaint that we get, we sort of categorise what's the main element of that complaint. People might have multiple bits of their complaint, but we tend to pick the lead one or the most significant one and just categorise it under that. So, for example, around communication or information, so people might be unhappy that they haven't been told something, or they found it difficult to get in touch with a particular member of staff or something like that. So that will be a typical sort of communication or information complaint. Section 2.12 is interesting because you can see about who makes complaints, and the overwhelming majority of complaints that we get come from family members. All our adult social care service users are vulnerable. Many of them are very poorly. Many of them are quite old with a number of health conditions, and it's not unusual for their family to be protective and want the best for their relatives. And so it's often the family members who will approach us to raise concerns about what they see as problematic. What we do in those circumstances is we make sure that we have the person's consent for the family member to represent them, and also for us, the organisation, to share their information with that family member, because that's an important part of the process to sort of get right. Because what we don't want is we don't want to have, if you like, a family member being unhappy, but the actual client is actually quite happy. So we need to explore those kind of issues right at the start. There's a section from 2.17 onwards about CHC complaints, which are comparatively very, very small indeed. One of the important elements of the complaints process is not so much about sort of individuals, it's about what is it that we can learn from this opportunity, if you like. Because sometimes when things go wrong, sometimes it can be somebody just having a bad day at the office, and on occasion, not commonly, but on occasion, it might lead us to have a look at a sort of a slightly wider look at things. So in section 3.1, there's some examples about the kind of themes that how we might address particular themes. So, for example, I've mentioned a lack of response to phone calls, and we might give an apology and make sure the individuals are reminded about the expected standards, and there are different ways of doing that, but that might be a fairly sort of expected response. I think the other thing is it's important, as I said earlier, to apologise, to say sorry for when we get things wrong, because that helps restore trust. Because as I said earlier, sometimes when people complain, they've kind of lost a bit of trust, they've lost a bit of faith, and they're not sort of happy with the service. So it's important to try and, as I said, re-establish that relationship and build bridges. From section, a few examples of some of the complaints that we've responded to over 23-24, just to give a little sort of flavour of some of the issues that people have raised with us. And I think I've tried to be fair and just kind of picked a few bits and pieces from our complaints. In terms of the complaints process, the council has several different complaints processes. The adult social care one is unique in the sense that you make a complaint and you get a response. What happens between those two bits is very important, but it's a one-stage process is the point I'm making, whereas the corporate process and the children's social care process, for example, will have multiple stages. Now, once you've completed your process from a complaints perspective, the local government and social care ombudsman is, if you like, the final stage for those people who remain dissatisfied. And section 4 outlines the numbers of decisions that we've had from the ombudsman over that financial year. NHS complaints, the ones that are related to CHC that I've mentioned before, those are handled by the Parliamentary and Health Service Ombudsman, but we haven't had any complaints looked at by them for a couple of years now. And in terms of the social care complaints, we've had a slightly smaller number than we've had in the past couple of years. And what I've done is I've just given some highlights from those complaints. And as I said, that each and every one of those is included in section 4. I mentioned at the start, and looking at section 5, is we get a number of what we call inquiries. Everybody who contacts the complaints team will be logged as either a complaint or an inquiry. Everybody gets a choice as to whether do you want to make a complaint or are you wanting a slightly low-key, a slightly sort of, if you like, less formal approach. People do, as I said, have that choice. Most people are more interested in just having a conversation with a team manager, possibly a senior manager, something less formal than a complaints response. Sometimes people contact us and the outcome is we're signposting them somewhere else, but most of the time they're coming to the right people first time round. And as you can see, section 5 just gives an indication about some of the numbers that we've had and the different kind of service areas that people might contact us about. And I think the one thing that we can say both with complaints and with inquiries is that if there's some fairly prompt action, constructive action taken by the operational services, either the team manager or someone more senior as appropriate to the situation, then we can more often than not come to a reasonably satisfactory conclusion for all parties. Lastly, in section 6, we also log compliments. I think the one lesson that compliments tells me is that adult social care gets far more things right than they get wrong. So in that sense, it's a bit of a barometer and sort of helps put things into a little bit of context that most people most of the time are happy with the quality of service they get from adult social care or from providers. Which is, I mean, I think that's generally a very good thing, that we try and have some balance. Section 7, advocacy. Advocacy is not a right under adult social care complaints, but we do consider advocacy for people when that's appropriate and when they want to have an advocate, and we might signpost people or refer people as we need to. Last year we haven't, this year, this financial year we do, but advocacy is always something we try and bear in mind to support people to make complaints or to have their voice heard as and when it's appropriate for the circumstances. And then the last section just gives a few examples and plans, and section 9 goes over the appendix 1 is the complaints process, just to give you a notion about how that works. As I said, we have a complaint received at the outset and a response at the end of the process, and the really important bit is what do we do in the middle. I refer to in here, I'll just find the right place. It's like a resolution plan. Basically what that means is it's almost like a risk assessment. It's how much time and effort is this going to take? Is it going to take some or quite a lot? And it's about being proportionate as well. So it's important to make sure that the right tier of manager is involved from the outset to make sure that we deal with somebody's issues as effectively as we can. So if it's a team manager issue, that's good. If it's a service manager issue, then it's a service manager issue. And on occasion, we might go to heads of service or higher if it's something that we feel that needs that degree of involvement. And the complaints analysis process, lastly, is just a little flow chart that's around learning from complaints. That's something we've recently introduced. Sorry, that's a bit of a whistle-stop tour, so I don't know whether anybody might have any questions or queries about the report or about complaints more generally.
Do any committee member? Councillor Ball.
Thanks, Chair. So it's just a quick one. Of 73% of family members, it is high. It's to be expected, because I know personally, if my mum was too sick and I had concerns, or she raised concerns, it would be me that would be making the phone call. How does it work, for example, if the patient is too poorly to be able to give consent for the complaint to go further? And just also, I'm wanting a little bit information about that active learning that we do. Are we actively getting in touch with people to get some of that feedback? And from the inquiries, rather than complaints, where does the learning come from that? Because I'm assuming somewhere you've got that log, but what do we do with that? Because if it's repeated inquiry after inquiry, that's not quite a complaint, but it's coming up time and time again. What are we doing with that information to make it better?
Yes, thank you for that. I'll just come to those 3 points. If I do them backwards, I've just scribbled them down there. In terms of inquiries, again, we do log them by theme, and if there are lessons, we do learn on occasion from individual inquiries. So sometimes people might say, oh, you might want to know this, but I don't want to complain, but I just thought you might want to know. There are occasions that I've known over the years where we go, right, okay, thank you. So even if we log it as an inquiry, it's on a par as complaints in terms of both the themes that people raise and also the opportunity that we might be able to improve services, whether that's through individual staff learning or team learning or manager learning, or whether that's something a little bit systemic where we might need to change stuff. So the inquiries and complaints, they're all reported through our governance arrangements within adult social care. And we also I also write a number of reports through the year which get scrutinised both by like a quality and governance group, as well as a kind of a slightly subgroup where they poke me with sharp sticks, as it were, and ask me questions about stuff. So in that sense, everything that me and my team gets picked over for themes and for opportunities to make changes where that's appropriate. So yes, I mean, I kind of skip over the inquiries bit in the report, that's the point taken. But it is, as I said, equally valid. So in terms of the active learning, we do want to make sure that if we do have some specific learning that's applicable beyond, if you like, individual members of staff, there's a process through Karen Martins, who sat at the back there. I don't know whether you want to quickly just describe your process.
Yes, I'm happy to come in. I mean, and just to add to what James has said, it is embedded
in adult social care, positive learning. So we do have a process, and it's very much linked to our audit framework. So what we do is we identify the themes, we put an improvement plan in place because it's very much linked to practice, and then we do audits to identify whether there's been any change. And if there has been change, then that's good, that completes that circle. But like James said, that's not just for complaints, it's for inquiries that we received. And we record these on our audit framework as themed audits. So we're continuously improving. And just to come back on the point that you mentioned about trying to capture customer experience, that is one thing that we're trying to improve all of the time. And just had a conversation earlier with Jerry about taking it to our People's Advisory Panel and talking to people who've got that with people with lived experience and share that report and get their feedback. So we're constantly improving and thinking about that. Thank you.
And I think the last point is about sort of relates to a person's capacity, whether they can or whether they can't make a complaint. If a family member has a legal power that's been, if you like, registered, then obviously that person can act on behalf of that person. We don't need their consent. If it's around health and welfare, or if people might have a legal power to manage money and they might want to make a complaint about something that relates to money, we would deal directly with the person with the legal power. That's absolutely fine. Where there's no legal power in place, we would make a best interest decision. And I must admit, in the 20 years I've worked in complaint, I've not known a family member make a complaint that's not in their family member's best interest. But it is a process that we would go through just to make sure that if the service user, for whatever reason, can't complain at all in their own way because they're so poorly, then we would just, as I said, make a best interest decision in conjunction with the family member that it is in their best interests to make this complaint. And as I said, I've not known somebody not act in a constructive way with their relatives.
Councillor Hardy.
Sorry, my question is about expectations. And I have two family members that are in the care of adult social services. And I have a family member that has continually complained about the service that they've received throughout because they couldn't balance their expectation of need to what deterioration was taking place. So deterioration from assisted living to care home, and the difficulty of the transition and admitting that a family member needed to go to a care home because, first of all, we weren't able to look after them. The assisted living wasn't able to complete what some family members thought they should, and they're now in a care home, and there's still doubt about whether they're getting the right care or whether it's the right place because of expectation, not because that is actually the best place for them to provide the needs that they have. So my question is about expectation of the person that is complaining.
Yeah, one of the things that, if people contact our team, I think one of the things that we do want to understand is what does a good outcome look like for them? And we're not the experts in assessment or delivery of care. So this is where I suppose where I talked about like a resolution plan comes in, because it's important for the complaints team to understand what the issues are for the person and what a good outcome looks like, and then involve the right people at the right time as far as the complaints process is concerned. So whether that's the team manager or the service provider or the contracts team or whoever it is, because people's expectations can be, I suppose, sometimes people can have expectations that are perhaps a little high. Sometimes people can have expectations that are perhaps a little low. But what's important, as I said, is to try and get that conversation going between the service provider or the adult social care social work side of the business with the family member, with the service user, to explain what's possible and practical and whether or not their expectations can be met, and if and the ways in which those expectations might potentially be met. So, for example, some people might not be particularly happy with care into their own home. So there are solutions to that which might be explored with the social worker that might, for example, direct payments. That might work for some people where you can employ your own carers rather than have someone else's carers turn up, as it were. So that's something that might want to be explored in certain circumstances. And similarly with with home care, it's about finding the right care home or finding the right solution for that person. And there's not always just one way that we do things. And I think the fundamental point is having the conversation at an early point about what can and can't be done and how it would work and how it wouldn't work, involving all the interested parties, I think, would be from a complaints point of view, the way I would want to see someone's dissatisfaction sort of worked through. That's not to say that everybody can have whatever they want, however they want it. There are rules about how resources are used, but those would be the principles that I'd want to stick to. I don't know, Karen, if there's anything that you wanted to...
Well, just to add, I think it's down to good communication. I think it's down to bringing in all of the professionals who are involved in that assessment process. And it's really difficult to manage sometimes it's wants versus needs and managing, but if we can communicate that information as best we possibly can to help the family inform their decision and support them, I think that's the most important thing.
And just being open and honest with people, or everybody being, whether that's family members saying, this is what I want, how's it going to work for me?
Councillor Hunter.
Thank you. A couple of comments and then a question. Yes, the numbers are low, so therefore as soon as you see the ones and twos, it looks as if it's on an increase. And it's nice to see the compliments going up, because a lot of people will complain but won't do a compliment. If somebody registers like an inquiry rather as a complaint, if they decide down the line they would like to change it to a complaint, is that option available to them? Or if because they've registered just an inquiry that it can't go to the next level?
People can change their mind whenever they want to change their mind. Just because they sign on the dotted line, as it were, doesn't mean they're locked in. So someone can escalate from an inquiry to a complaint. And there are a couple of examples of where we've logged it as a complaint and they've gone, actually, I don't want to complain anymore, so we might have logged that as withdrawn. For us, it's a bureaucratic process, but it shouldn't be bureaucratic for the person. They should just be able to, hopefully, as painlessly as we can, just help them to get some sort of resolution to whatever it is that's making them unhappy in the first place.
Do any other councillors have anything to say at this point? No, well, in that case, I'll bring Derry Nugent in.
Thank you. It's sort of a slightly an adjunct to what you've been talking about today, which is a very comprehensive report and I think gives a really good picture of the process and the outcomes from it. I suppose looking more widely, the question, and it might be for Karen, is that if as a council that you need to be aware of the experience of receiving care in the county, then obviously this report gives only a partial picture because these are the people that are involved with adult social care or have come in through that particular route, and there's that's the pathway they're on. And I think what we're all aware of increasingly is that people are arranging their care themselves, either because they're self-funding themselves, either in a care home or their own care, or people, they've got this growth in people providing care locally. And I suppose it's just that we need to be aware of that. So the level of satisfaction and the actual experience of people receiving care in the county is wider than what, and I suppose it's about how that experience is also captured, because I think that's really important for you as well, because that helps you with sort of like understanding the whole market, doesn't it, and what people's satisfaction and experience of different providers is. Yeah,
I guess just in answer to your question, Derry, I mean, there are various mechanisms in adult social care where we're working with people who are private funders, so we may support them through that process. So we'll gather that information through that. We've also got processes through best interest assessors who do DOLs, who are people who are in care homes. So we're capturing that information there. But so there are mechanisms that we can get that feedback, but it's something that we definitely need to improve on, and I think we need to be honest about that.
I'd also add that there's like a service user kind of experience group, which I invited myself onto the group a little while ago, just so I can tip up bits of complaints. But it is about those. The focus is a broader one, about people's sort of more day-to-day experiences than the slightly sort of smaller complaints end of the business.
With that, the committee's recommendation to note the content of this report and also to identify additional areas for scrutiny. In respect of that, I think we've got a lot to digest there, that if anyone's got anything on that they email me as a chair and Rebecca about that, if there's anything we want to bring up at further meetings on the back of that. So can I ask that we note that report, committee, and then say thank you very much. That was a very detailed report, and thank you very much for your time on that one. Thank you. Okay, I'll carry on with the agenda if you just bear me 1 second. It's 7.1, forward plan, to note the latest forward plan of key decisions. That's page 69 to 80, if we can note that. 7.2, health and wellbeing overview and scrutiny work programme, to consider the work programme on page 81 to 86, and again feel free to email me outside of this meeting. Point 8, urgent business, if there's any, to consider any such urgent business. I don't have any. And then point 9 is to note the next meeting of the Health and Wellbeing Overview and Scrutiny Committee is held on the 7th of January 2025. So happy Christmas, happy New Year, all that kind of stuff. Thank you very much. I will close the meeting. Thank you everyone for attending.